Hello, podcast listeners. We know podcasts are a great way to catch up on a program that you may have missed on KSJE, and it's provided as a free service of this radio station. But you know, KSJE is now listener-supported, and so while you enjoy this podcast, we hope that you'll also take some time to join KSJE. Become a member today. It's quite easy to do. Just go to our website at ksje.com/support and pick the level of support that best matches your budget. Thanks again for listening. Here's your podcast. This program on KSJE is supported by Citizens Trust and Investment Corporation, providing a competent, innovative, and caring team of professionals to serve wealth management, trust administration, employee benefit plans, retirement planning, and estate settlement needs. Find out more about Citizens Trust and Investment Corporation at 505-599-0181. Well, let me turn to my guest who is here with me this morning to talk a little bit about stroke and Stroke Awareness Month. Tina Bieberdorf is here from San Juan Regional Medical Center. Good morning.
Good morning.
Welcome back.
Thank you.
Good to have you here.
Oh, glad to be here.
And this is an important thing because strokes are still a pretty big problem in our country, right? They're one of the big killers of people, isn't it?
Absolutely. We're making improvement. We used to be the third leading cause of death, but now we're the fifth leading cause of death in the United States. So it's still affecting not quite 800,000 people a year. So that's a pretty big number.
Still a big number. That's true. And a big number here in San Juan County related to that, right?
It is a big number in San Juan County. And it's the leading preventable cause of disability. So there are things that we can do to modify our lifestyle, which it's hard to do, and people don't want to hear that, but you can definitely prevent it. So.
And folks in the medical field, like yourself, can determine if we are at risk for stroke, correct?
Mm-hmm.
I mean, there are things about our appearance or presentation or lifestyle that sets off the warning lights in your brain that says this is could be a stroke waiting to happen, perhaps, right?
Absolutely. Actually, the American Heart Association and American Stroke Association in October of 2018 updated the cholesterol guidelines to really include a monitor that if a person is at risk at 21 years of age, then we start monitoring their labs, and if their labs are elevated. So if they have a high cholesterol, even at 21 years of age, then we're starting them on cholesterol medicine. So those guidelines just came out in 2018. So.
Interesting, because a lot of us, I think, feel that victims of stroke are older, usually.
Right.
But we're seeing them in younger and younger people, perhaps.
Yes. We've actually treated a 14-year-old, and we've treated people, over 100 years old. So it really... obviously, the younger generation is not necessarily maybe the cholesterol, but there's really physical, pathophysiological abnormalities that the person that age can be susceptible to. When we're born, there's a hole in our heart that when we take our first breath, it closes. And sometimes some people, it's not very, it's pretty rare, but the hole doesn't close, and we don't find it until...
There's a problem, I suppose.
Exactly. Well, a little clot develops and moves through the hole, and then it goes up to the brain, and then they have signs and symptoms of stroke. They can have an aneurysm rupture.
Right.
So the younger crowd really. So it does affect all range of ages.
Okay. Well, it's a good thing you're here to let us know how to spot these things and what to do about them. And so your job at the hospital is to kind of help people who are at risk or who have suffered a stroke.
Yes and no.
Okay.
So for stroke coordinator for primary stroke center certification, my job is really to, if we get stroke alerts and if I'm available, I'll go to the emergency department, be there as a resource, try to help the nurses who, we're just playing cards.
Mm-hmm. Oh, dear.
Yeah.
Don't get us started on that. Wow.
Yeah. And it's Nurses Week, too. So
that's right.
Thank you for the nurses for everything that
nurses.
You do.
That's
Absolutely.
true.
Yeah. So I develop the policies and protocols. So I make sure that we do follow the guidelines for the cholesterol guidelines, for monitoring of blood pressure and that sort of thing.
Okay.
So I'm not necessarily ordering that. I'm just a resource for the physicians and the nurses that these are the guidelines. This is proven best medicine. This is the evidence that we need to really focus on following.
And as you mentioned already, those guidelines are evolving. I don't want to say changing, but evolving over time as we learn more about what causes stroke and some of the other risk factors, correct?
Correct.
As you mentioned, some of those cholesterol levels at a really young age could be something to watch.
Absolutely. So cholesterol is one thing, but really the biggest factor that has happened in the last 7 years really is endovascular thrombectomy. And what that means is that I know that my grandpa suffered a large vessel occlusion stroke, meaning he was totally paralyzed on one side of his body, and so he didn't move his arms, he couldn't swallow very well, and couldn't walk with his legs either. But now we have treatment for that, so we have tests that we can monitor for that, evaluate the patient, and if they're eligible for that treatment, then they'll literally go in and evacuate the clot with a certain thrombectomy catheter, and extricate the blood clot. So that's showing really good outcomes. So as far as guidelines, then, there's studies going on about stroke all over that aren't necessarily published yet, because we really want to make the best practice for the patient. So that's really evolved in just the last 7 years.
Sure. And again, it all depends on the type of person who's presenting to you, and other things, and maybe other health problems that they may or may not have, and all those things. I know you can't make a blanket statement that says everybody who has a stroke can get this treatment.
Correct.
Because they're all different types of strokes, too.
Absolutely, yes.
Right?
So there's two types of strokes.
Okay.
One is called an ischemic, and that just means that both of the types of strokes are an abrupt blood flow disruption. Say that 5 times real fast.
All right. Yeah, I'll let you do it.
Right. So an ischemic is, as you can see, the yellow is the actual cholesterol, and that's blocking the blood flow. It can actually be a blood clot as well. And anything that's blocking the blood flow, which we know blood is carrying oxygen.
Right.
So when the brain has not enough oxygen, that's when we get the signs and symptoms of stroke. Hemorrhagic is the other type of stroke, and that's when the actual artery ruptures. The signs and symptoms are exactly the same. We don't know the difference when they come into the emergency department until we actually get a picture of their head. So we'll get the CT or the CAT scan of their head.
Right. And then you can tell if there's a blockage or a leak, I guess, for lack of a better term.
You can see the blood.
It's my non-medical background right there, using the term like leak.
Yeah. Well, and that's true, because it could be a small leak. The only major difference is that with a hemorrhagic stroke, it's not uncommon for the person to be going, it's a sudden onset headache. We call it a thunderclap headache.
Right.
And they'll say it's the worst headache of my life, and they'll just be rubbing their head. So people who have migraines, it'll still be a different headache.
Not the same as the usual migraine pain that they experience.
Exactly.
You're saying. And so they will know there's something different happening.
Exactly. Regardless, if you have a different migraine, get to the emergency department. Call 911 and get there. So again, two types, hemorrhagic and ischemic. They're both disrupting the blood flow, which is lack of oxygen to the brain, and that's what gives us our signs and symptoms of stroke.
I see. And then I would assume that then, depending on where that is happening in the brain, then depends on what's affected in the brain, and then how that presents itself in your body, right, as to what you can or cannot no longer do, perhaps.
Absolutely. So our brain does a lot of functioning that I think we forget sometimes. Like, it makes us have motor function, like walking. So having motor disability, like one of the symptoms is maybe not being able to move one of your arms or even a leg. Speech difficulty. So in our area in our brain, they have slurred speech. It could be not making any sense at all, or not even being able to talk.
Is that hard for the person who's suffering the stroke to realize?
Yes.
Because it seems.
It's very frustrating, and when it's first happening, it's very frightening for the stroke patient because they don't know why they can't talk.
I see.
And the other aspect is when they are trying to talk, and it would be like I'm talking to you, and all of a sudden I just start talking about how now there's 20 dogs in the room, and one's fixing to bite you, and you're looking at me like you are now.
Tina.
But I'm really thinking I'm talking to you in normal. I have no idea why this is coming out. So
different words, but your brain is telling you you're still on the same train of thought.
Absolutely.
I guess, right?
And that's right. So that's there's a few typical signs and symptoms of stroke, but again, we can tell kind of what artery is affected on the signs and symptoms, and go from there.
Right. And some of these things are pretty major things that you can notice. If your arm is numb or your leg is numb or you can't walk as well, but it could be even a little lesser to a degree, correct? Sometimes the foot drop or things along that line that could be another sign?
Correct. So we want to be fast and
Okay.
recognizing stroke. So the B is for balance, and that's where we're talking about it may not be all that serious to the patient in actuality, but it's not uncommon for someone to say, I've just been falling for the last 3 days, and really there's no rhyme and reason why they're falling.
Okay.
So balance is really in the back of our brain,
Okay.
and it's not an all that common stroke, but it still is a stroke. It is still a clot per se that has blocked the blood flow, so they need treatment for that.
Okay.
The E is for eyes. Same scenario. I could be looking at you. All of a sudden, I'm like, it's a sudden onset. So back to the balance. It's sudden balance loss. So sudden vision changes. So it's
Okay.
not like I forgot my glasses and I have blurred vision. This is I'm looking at you right now. I all of a sudden can't see half your face, or I can't see peripherally, like I can't see the door to my left. There's not a time set, so it could last 5 minutes and it could last 4 days, depending on when the patient comes and actually does get treatment, whether that will ever come back.
Interesting.
So vision changes as well. So that's the B and the E. Fast, the F is facial drooping. Ask
Right.
the person to smile. If their smile is off from what we are normally seeing, crooked in any way, not moving on one side. Arms, ask the person to raise their arms. If one arm can't raise as equal as the other or not at all, and again, it could be a leg, but arms is easy to remember.
Right.
And then we have the speech, the S, and I kind of talked about that already.
Right.
One of those symptoms is a 73% chance that the person is having a stroke. So the T is time to call 911, because time is brain. We've got to get blood flow returned back to that area of the brain if at all possible.
Right. The more time that passes, the more potential danger, damage happening to your brain
Absolutely.
from whatever's going on up there.
Correct.
And that's what we're talking about. We're showing you the acronym FAST. You've added the two letters B and E, so be fast rather than just fast. And again, B is balance and E is eyes, everybody, when you add that to the FAST acronym as to how to spot the effects of a stroke. It doesn't have to be all 6 of these things either, right? It can be just one.
Correct. So the B and the E are really rare strokes. They're in the back of the brain. So we just want to make sure that we still capture those, because, again, they still need treatment.
Sure.
So,
Well, it's important that folks realize, I think, that is also could be stroke related.
Absolutely.
And
yes.
so that's important to include that when we're talking about this acronym. So,
Right.
so it's interesting and scary, I think,
is
for a lot of
scary.
folks. Because as you mentioned at the beginning, I think this is the leading cause of disabilities for folks.
It's
or
the
one
leading
of them.
preventable
Thank you.
cause.
That
Yes.
was what I was trying to remember.
Yeah. So we can prevent that, because there's modifiable and non-modifiable risk for stroke. Non-modifiable is, although we would like to change our age, we can't change our age, race, our sex. But things that we can modify is like high blood pressure, which is the number one cause of strokes.
Right.
Diabetes, we can control our sugar levels. We can modify our diet and really start to exercise. I'm looking at my cheat sheet.
That's okay.
Smoking. I think we all know the detrimental effects of smoking. And then, of course, the vape
vape thing,
cigarettes
right.
are coming
There's
coming out
concerns about
in
those
the
too,
studies.
right? Because a lot of folks think they're healthier than
Yes.
cigarettes, and they
Right.
may not be. I think there's still some out. We're still waiting on some studies about this.
The studies are starting to come out, and they're not good. They're showing that it's the same detrimental effects as regular cigarettes. So I think it's many years before we do know the actual effects. It's just like smoking a regular cigarette. How long did we
Right.
take to figure
Here
out
we
how
are
long
back in the
tobacco-
1950s again, talking about smoking, right?
Yes, exactly.
Yeah, when we didn't quite, or maybe we did know, but we weren't promoting the fact that the cigarette smoking was dangerous
Right.
to your health. But-
Correct.
So be aware, everyone. Yeah.
Atrial fibrillation is an irregular heartbeat. If the blood is not flowing, it starts to clot. So in atrial fibrillation, we have a high potential to develop small clots, and then those eventually will move up our carotids and then go to our brain, and then hence
Cause a
signs and
problem.
symptoms of stroke.
Right.
So atrial fib can be it can be fast, but we can control it with medications, and then they also need to be on blood thinners so the blood doesn't clot when it's not moving as well.
I see. Gotcha.
Long-term alcohol abuse.
Okay.
So
That's another factor.
It is.
Contributing factor?
It is. It's lower on the list, but yet again, it's still, it's prevalent in our Four Corners area, unfortunately. And so our liver breaks down the alcohol. So that
over time, I imagine if you're abusing that liver is not going to do that as well.
Right. Your liver's not going to work. And our liver helps make our clotting factors. So then again, here we go. We're either not going to clot or we're going to clot too much. And so then that gives us the potential to have a stroke.
Got it. Interesting. So, but these things can be modified, prevented with
Correct.
Medication, with lifestyle changes, all these different things, right?
Correct. Yes,
and that's
absolutely.
what we're talking about.
Yeah, and that's hard for everybody. But we were talking about earlier about preventable measures,
right?
And so when we go to our primary care physician and get our physicals, American Heart, because high blood pressure is that number one cause, they've really tightened up the parameters. So really, there's stages of high blood pressure. So anything greater than 120/80. Then American Heart, American Stroke Association is calling that hypertension. So your physician will say, okay, what are we going to do about this?
Right.
There is white coat hypertension, which I know some people in my family have. And that's when it's just, the doctor comes in the room and your blood pressure goes sky high.
Oh, I was going to ask
I'm
you about
sick.
that.
What
right?
does that mean?
I get nervous coming to see the doctor.
Exactly.
So,
Yeah.
And
right.
So they realize that, I guess, in some
absolutely.
cases, right?
Yes, and it's proven that it does make people nervous, so it's unfortunate.
I wonder why.
Right. And then,
They're very nice people, most of them. Yeah. So
I think it's because I can only speak for myself. I don't really have it. I'm not going to tell on somebody I know who has that.
Okay.
But I know when he goes in the office, he is so scared about what they're going to tell him he needs to do or what he has, and it's
Right.
like, you're a healthy guy, you're fine, just go in and relax, you're just getting a physical. But they'll just recheck it later, and, once the patient's relaxed and I'm not going to, have a detrimental diagnosis in here, then I'm going to be okay. So they'll just monitor their blood pressure and say, okay,
sure,
Scott, we're going to do some exercise. We're going to change our diet, monitor in 6 months, have a follow-up, and really just watch for trends on the blood pressure. And then if it doesn't come down, then they will start, let's talk about blood pressure medications. One aspect I do want to really talk about is once you have any kind of blood pressure meds added to your regimen or cholesterol meds, if those are not working for you or they don't agree with you or they make you feel bad, report that to your primary care physician, because there's other avenues that there's a lot of drugs out there that we can really try that maybe not give you those side effects. So don't just not take your medicine. The medicine
right.
helps. Yeah. And people do, because it's a side effect, unfortunately, but there's other medications that we can try and then and see what's the best fit for that particular person. So,
good advice. And because, again, the potential of not taking your meds and then suffering a stroke certainly is going to be a lot worse than any side effect you can talk about. I would think.
Yeah. Leading preventable cause of disability.
Right.
Right.
So there you go. And again, does not discriminate, really. As you mentioned, you've seen patients younger, older, rich, poor, ethnicity, doesn't matter, right?
No, it doesn't. And that's, a non-modifiable risk factor.
Right. We are what we are, who we are.
Right. And I know I wish we could change age and, turn back time a few years, but unfortunately we can't. So as we get older and your
face may look 29, but your heart and your brain is still whatever age it is.
It is.
Yeah.
Right. Yeah. And that's the unfortunate thing of us, being the young 15-year-old eating cheeseburgers and fries, and, we're running track or in basketball. We're more active when we're younger, and then we settle in our lives.
Right.
And, I'm like, oh, well, I'm in school. I work 40 hours. I don't want to go and run. I don't want to exercise. So it starts to build up. And
sure. Well, and I think, too, as folks get older, their metabolism slows down, as some folks may say, and maybe they were skinny all their life, and then all of a sudden things start to widen a little bit, right?
Yes.
And
Pear shape.
and things are happening, right? And so the bodies are reacting, and so that puts stress, I think, on if you've gained some weight and what have you. That's also other issues that are going on.
Oh, absolutely.
Right?
Stress is it's a risk factor in that, like for myself, when I'm stressed, I'm a cheeseburger eater. So I'm on up there in age now. I'm in that risk factor age that now I've been eating cheeseburgers for a while. So I really have to watch my diet, exercise, and just pay attention to that. Get my labs checked, get my cholesterol levels checked, and
Sure.
and do that once a year. And we do. And,
Right.
Yeah.
Be able to monitor that and know if there's a change.
Right.
That's the important thing as well.
Absolutely. And again, the American Heart is saying we need to start monitoring at an early age and getting those young folks on the cholesterol medicine. Obviously, they'll, talk about physical activity and diet changes first. We're not going to go to a medical regimen first unless their cholesterol levels are just off the charts. And it will be a while before this person makes those changes and be able to adjust their lifestyle. So then probably the recommendation would be to take medicine, but we'll work with diet and exercise first.
Okay. Tina Bieberdorf is my guest this morning. She is the stroke coordinator at San Juan Regional Medical Center. May is Stroke Awareness Month, everybody. So that's the reason for our topic and our conversation this morning. As we're learning, it affects people of all ages, and it is still one of the top, 8 leading killers in the country?
It's the number 5 killer
Okay.
of in the United States, and
Right.
then it's the leading cause of disability, preventable.
Preventable disability. That's what we're talking about. There's the number 5 cause of death and leading cause of disability in the United States for having strokes and suffering from strokes. And again, can be prevented.
Can be prevented. We just have to be conscientious of diet and exercise. Hereditary genetics play a little bit of a role in there. For example, my grandpa had a stroke, which puts me a little bit at risk, but if my mother or my father had a stroke, that puts me more at risk. So it's kind of generational, but
Okay.
the genetic factor is still there. But my family has high cholesterol. I know that. So I can still modify my cholesterol. There's very few that, despite diet and exercise, still have to be, on a medication regimen. But it's still up to me to modify my lifestyle so
Right.
I don't have a stroke.
And once you know about it, you know what to watch
Right.
for and things like that as well. Or if you know that you have a family history, that's something to be aware of as well.
Absolutely.
I want to give a shout out to we have a viewer watching from Durango who says hello on our Facebook page.
Oh,
so hello
hello.
back, Durango.
Hi.
Great to hear from you this morning.
Yes.
And thank you for tuning in and hopefully learning a little bit more about how to prevent this from happening. And so when we see a lot of folks and a lot of older folks suffer from strokes, and for them it may be harder to bounce back, correct?
Yes, it is harder for them to bounce back because, unfortunately, the older that we get, then we do have all those risk factors against us, like the high blood pressure and diabetes. So diabetes, even though maybe we've controlled our sugars for 20 years of being a diabetic, it still affects our arteries and our veins and can make them more susceptible to having a hemorrhagic stroke, but cholesterol or blood clot, for the ischemic stroke and,
Right.
and blocking that as well. So because we have that stigma of older people, and it's only because when we get older, we do have all those risk factors kind of compounding up on ourselves.
Right.
So
And so it can be more difficult to get back from.
yes,
Is what you're
yes,
telling us.
Absolutely.
But as you mentioned, there's a lot of new advancements in some of the techniques and treatments for a stroke, and you mentioned some of the things to be able to get rid of the clots and to open things back up again, and,
Right.
and really time is what is so important, and we're talking about any of these types of treatments.
Correct. So there's a clotbuster medicine that we can give for the smaller strokes. So the endovascular thrombectomy is for the large vessel occlusion strokes. So that's really like if you put your finger under your chin here and you can feel your carotid.
Right.
That is what is feeding our brain the blood. So that's a large vessel occlusion. Those patients, there's a particular assessment that we do so we can assess them and think, oh, this is a large vessel. We need to do some additional testing so we can identify it earlier. For the smaller strokes, the clotbuster medicine can only be given for 4.5 hours from the onset of symptoms. That's why it's so important to call 911 and get to the emergency department. So patients have to be eligible to receive that medicine as well. So if they're already on quote unquote blood thinners, we'll check their labs. So if their clotting factors are still within normal limits, depending on what else is going on with the patient, then perhaps we can still give the clotbuster medicine. But that's why T is so important for time, is to get to the emergency department. I do a significant amount of health fairs, and inevitably, at least one person will always approach my table and say, my aunt was having slurred speech, and we didn't know what was going on with her, so we decided we just put her in the car and drive her to the hospital. Well, because we're a primary stroke center, we have developed policies and protocols that when the EMS, the ambulance, picks up the patient and identifies the signs and symptoms of stroke, they call the hospital and notify us ahead of time. That stroke alert goes out to myself, to radiology, so the CAT scanner's ready to go. The lab department is ready to go. So when that stroke patient hits the door at the emergency department, the whole entire team is there literally waiting. And then there are time metrics that we have to meet because time is brain, and start the treatment. So one of the most important things is to know the last known well of the patient. So symptoms, she was fine at 8 o'clock. I went outside. I came back from the yard at 8:30 and found her on the floor.
Right.
So her last known well would be 8 o'clock.
And that's important for you to know.
Absolutely. So 8 o'clock was the last known well, and let's say they called immediately. EMS came, and they get to the ER within 30 minutes, which is not unusual. We've had that happen, to get there really quick. Then they're time eligible for the clotbuster. And then we have a small checklist that we do, kind of ask a history. Is the patient have on anticoagulants? Are they on the blood thinners? What else do they have going on?
Right.
That will... we just have to check their eligibility to make sure they could get the clotbuster medicine. And so then we administer that. It's through your IV, and it's over an hour. And then we'll see the outcomes for that. Usually we monitor for 3 months. So really the outcomes at 90 days for getting the clotbuster are better if you are eligible and then you don't get it. It's obviously it's up to the patient,
Sure.
We will explain the risk and benefits for all of that when they come in.
Right. And the idea, again, if someone's coming in by private vehicle, you've lost some of that prep time of getting everything ready. So once they hit the door of the emergency department in a private vehicle and you realize they're having a stroke or have suffered a stroke, then you've got to clear out the CT scan, and you've got to move whatever patient's in there out or get them in there.
Absolutely.
And it's a little bit more complicated, I suppose, right, to start those series of treatments to decide just how serious this is, and then what the options are going to be for treatment.
Yeah. It's not only a delay for the patient on the CAT scanner, but for the stroke patient. Again, time is brain, and we have to really clear out all. So, lab has to drop what they're doing and go.
Right.
And which, when we get the alert from EMS, they'll give us an estimated time of arrival. So it can be 3 minutes, it can be 10 minutes, and but nevertheless, the whole entire team is there, prepared and waiting for the stroke patient to get to the emergency department. So it definitely creates a delay when they come up in private vehicle. You have to come to the ER. Are you going to park and have that person walk to the emergency room door? Some people drop them off at the door, get a wheelchair. Then, wheel them in, and we start asking her questions.
Sure.
And, the front desk is also, they're trained in stroke as well. So as soon as they see the signs and symptoms, or people will say sometimes, I think I've had a stroke, and then boom, they're taken immediately to the back. The physician looks at them right quick, and then, yes, this is stroke, send a stroke alert. And, sometimes it's ruled out, and that's a blessing, for
True.
that particular person.
Right.
But regardless, we just call the alert just to rule it out.
Sure. And I don't want to leave the wrong impression that if someone shows up at the emergency department in any type of transportation, whether it's ambulance or private vehicle, or they walk up to the door, they're going to get seen and treated.
Right.
I mean,
yes. Oh, we will treat.
Yeah.
We'll treat everybody.
Right.
But
the ambulance is the best way, because you can start some of those treatments en route, and if it's a 15-minute trip or 10-minute trip or however far away you are, you can start getting some of that, as you say, time is brain, some of that stuff happening right away.
Yes. I'm going to say it's a simple thing, just like starting an IV in the ambulance, but sometimes that's not the most simple thing, and sometimes patients are difficult to get that kind of access on. But, EMS can tell us that as soon as they roll in the door, these are the treatments that we've already done. Here's your labs. So that
already.
So really, the treatment starts as soon as the ambulance arrives to that patient, and then it's so detrimental to our brain.
Right. Very important.
We need to be fast and getting blood flow.
There you go. And I was just going to say, we only have a couple minutes remaining, so if you wouldn't mind going over the Be Fast acronym once again for us in our final moment so we can know what to be watching for. We have the FAST acronym on the screen right now, but they've added B and E for Be Fast, and that stands for balance.
Sudden balance loss, sudden vision changes.
E for eyes.
E is for eyes. Fast, so facial drooping, ask the person to smile, any kind of abnormalities or face, one part of the face not moving.
Right.
Arms, ask them to raise their arms. Can they raise both of their arms, and maybe one's weaker than the other? Speech, the S is for speech. Speech difficulty, it can be no speech, slurred speech, or psychobabble, for lack of a better word.
All right.
One of those symptoms is a 73% chance that the person is having a stroke.
Just one.
Just one
of those.
So T is time to call 911. Please call 911.
All right. Be fast, everybody.
Be fast.
That's what you should remember when we're talking about stroke. And this is Stroke Awareness Month. So good information. Tina, thanks for coming in.
Thank you for having me.
Appreciate your time.
Absolutely.
Thank you.
Thank you.
This program on KSJE is supported by Citizens Trust and Investment Corporation, providing a competent, innovative, and caring team of professionals to serve wealth management, trust administration, employee benefit plans, retirement planning, and estate settlement needs. Find out more about Citizens Trust and Investment Corporation at 505-599-0181. This program is supported by San Juan Health Partners Urology, providing a wide range of personalized services for the whole family, including children. Our caring professionals are dedicated to helping meet your urology health needs with skill, experience, and service you need. For a complete listing of our services and to learn more, visit sanjuanhealthpartners.com or call 505-609-6300. San Juan Health Partners Urology, a division of San Juan Regional Medical Center. Did you enjoy that podcast? We hope that you did. And if you did, share it with your friends. And if you really want to keep podcasts like this coming, please support KSJE. You can do it easily online at ksje.com.